Yes,
Yeah,
yes.
yeah.
Yes.
Shivani, meanwhile, are there your other friends, anybody who has joined?
Yes, sir.
So request them to at least keep their video on so that
Huh.
we can have the good interaction, right? And you can start your history part.
Yes, sir. Sir, I am presenting a case on acute flaccid paralysis on child in children. I am Dr. Shivani Patel, third year MD pediatric resident from MK Shah Medical College. Sir,
I think, Shivani, sorry for interruption, for the postgraduate, for the exam or anywhere presentation, never make the comment that what is the problem with the patient.
okay.
Right. You can say that just I am going to present the case, not necessarily even the CNS. What actually you have made the title CNS may not be the real CNS problem, maybe something else. So
Yes.
always don't give the title to the particular case presentation, even in the exam, right? Okay.
Sorry. Sir, I am presenting a 3-year, 5-month-old female child named Krishna Kaneria, Hindu by religion, born of non-consensual marriage, residing at Palanpur, belonging from lower socioeconomic class as per modified Kupuswami classification, and informant being father seems to be reliable.
Second thing, never relieve the identity of the patient.
Don't speak the name of a patient.
So not name of the patient, and even suppose if you are going to present the photograph, see that the identity is hidden. Right?
Mm.
Identity of the patient should not be revealed. Even in your description, suppose some consultant has seen, don't mention the name of the consultant. You can say neurologist or pediatrician, whatever it is, because our intention is not to carry any impression to others, right?
Yes, sir. Sorry, sir.
So
Sir,
this is, I will say, this is the thing that with the multiple presentations, all the points will be clear, not to even to you, to other students also. And ultimately it makes difference in your presentation. It makes difference. So suppose if you go for more presentations, I'm sure in the MD examination, your presentation will be going to be the fantastic. Right?
yes, sir.
Please carry on.
Sir, presented with chief complaints of weakness in lower limbs in 7 days, not able to move lower limbs since 5 days, and weakness in upper limbs since 5 days, and associated with not able to sit from lying down position, lying position since 5 days. Uh, she was relatively asymptomatic before 7 days. In the morning, when she tried to get up, she could not stand properly and fell down, and could not move her legs but could move. Hello.
I think please others should mute themselves.
Yeah, sir, I'm
Okay.
taking care. No issue.
Please.
But could move her legs when on bed. And gradually, over a period of 2 days, she was completely unable to move her lower limbs. And then with the same days, along with that, parents noticed the weakness of upper limbs as she was not able to hold things properly. Simultaneously, she felt difficulty in sitting from lying down position. With a negative history of.
Anyway, can you stop sharing for a while? Shivani, I hope that you know how to stop sharing, because whatever the information you have provided, let us try to understand. I think at the top, there may be the stop sharing icon.
Yes, sir.
Fine. Very good. Who are your other friends? Are you there? Anybody? Any other student? Yes, Dr. Jay.
Hello, good evening, sir.
Good evening. You are PG student, Dr. Jay?
Yes, sir.
Can you give your introduction so that I think all others can also follow and I can also understand?
Myself, sir, Dr. Jay Karya, the colleague of Shivani Patel, and I'm also from the MK Shah Medical College.
Right, from the same institution.
Yes, sir, same institution and same batchmate.
Okay, very good. And Akshat Desai is also from the same place?
Yes, sir. Good evening, sir.
Good evening, good
I
evening.
am Dr. Akshat Desai from Dr. M.K. Shah Medical College.
Fine. I think there is a good representation from Yogesh Medical College. It's a good thing. Anyway, let us now try to, I think you know what I want to share with you, that in the case discussion, go for the maximum participation, interactions. You can give your, I will say, interpretation, your understanding, your possibilities. Even if you have some doubt, you can raise the question. And I think in that way, we can learn in a better way rather than just what she presents and we all of us attend. I think purpose may not be served, right? So that's the thing. I
Yes.
hope that you attended the first slide. What Dr. Shivani said, that here is a 3 years and 5 months, so almost 3.5 years old female child. Shivani, what is the total duration of the illness? Shivani, unmute yourself. You are muted. Unmute yourself.
Total duration of 7 days.
Okay. And what was the first complaint? You said first relatively asymptomatic before 7 days. What you mean by the relatively asymptomatic?
Sir, she was completely do their her routine works, standing, playing before that night.
Okay. So is it the term to put over here that the relatively asymptomatic? Or when, in which situation you will use this type of the phrases that relatively asymptomatic? I think here what I want to make the point that before this, I was the previous day night, when she went to bed, probably she was absolutely all right. Am I right, Dr. Shivani?
Sorry, sir.
Before, I will say she developed this problem in the morning,
Yes, sir.
previous night when she went to the bed, she was absolutely all right. Am I right?
Yes, sir. Completely all
She had
right.
she had no any complaint.
No complaint, sir.
So I think here in this situation, is it the right way to put this relatively asymptomatic? Because in the exam, you know, when you are using this type of the terminology, phrases, clauses, examiners are going to ask you what you want to convey.
Yes, sir.
Anybody, any other person, that in which situations you should use this information that relatively asymptomatic? Anybody? I think Akshat was there, Jay was there. Are they or not?
Questions, unmute yourself and answer.
Yeah, I think there is some problem of net issue on their side, Lata.
Maybe, sir, they're in word and NICP, so maybe a bit.
Yeah, I think so because because Shivani is also not seen, so probably maybe due to the net problem.
Someone wrote in the group chat
Yeah.
the answer, Harshini.
Yeah.
Somebody
I think the
Yeah,
problem
it's
is
a Harshini who has mentioned something.
We use asymptomatic phrase in case of any abdominal pain or fever.
sorry, what I think due to some net issue, all the students from the MKSH are not seen on the screen.
Let me see.
Meanwhile, if any other person is there, I think Harshini, what Madam mentioned, is there any person?
Yes, sir. Harshini has answered.
Okay. So what do you mean by that?
She has answered.
In which type of situation you will mention the relatively asymptomatic? Anyway, let me make the point clear. These type of the things in the exam may create unnecessary issue, or I will say it may waste your time in the discussion. When I will say it is a sharp, acute problem, I think there is no need to mention the relatively asymptomatic. But in some chronic disease, that patient is brought to you with some acute problem. Suppose simple, if I give the example, there's some child which is brought to you with this altered sensorium and or I will say impairment of consciousness and seizures. In such a patient, if you see that the child is brought with this complaint, but once you go in the details, that before the development of this issue, whether the child was absolutely all right, then the parents may come with the more information that no, I think since few weeks, not keeping well, decreased activity, maybe complaining sometimes headache, occasionally vomiting, mild fever was going on, she was not eating properly, then all the symptoms will come out. And then we understand that, of course, the seizures and the altered sensory, which is a day or two, but all these problems were going on since few weeks or months together. And then it gives us the idea that probably it's a chronic disease. And if you think, suppose CNS infection, you will get the idea that rather than acute bacterial meningitis, it is likely that the tuberculous meningitis. Because the stages of tuberculous meningitis, that the stage 1 is non-specific. Just altered, I will say, behavior or even the personality, decreased appetite, some poor school performance, which will be the non-specific symptoms, which parents may not be able to understand. Later on, maybe some localized, that the headache, vomiting, early morning, and then maybe altered sensorium, and then the seizures. So in this type of some chronic disease, similarly with chronic liver disease, that means some hidden symptoms, which probably parents may not give the much importance, or they may offer the explanation something else, but which is important for us. Shivani, in that situation, I will start my story. The child was relatively asymptomatic before these problems or complaints, but on detail asking or digging out, they mentioned that some problems were since few weeks, and therefore I am suspecting that it's not the acute condition, but it is some chronic condition, maybe the chronic renal problem, maybe the chronic liver problem, maybe the chronic CNS problem, some CNS degenerative disorder or something like that, right? But here in your case, Shivani, you said that just in the morning, she found that not able to get up. And then the weakness at the lower limb, upper limb, various things you have mentioned. Anyway, what will be your interpretation from this description, the narration? Shivani, what will be your interpretation? For undergraduate, if just they describe the story, it's well and good. But for the postgraduate, ultimately from the information, you have to derive that what you mean by it, what is your interpretation, what is your inference.
Yes, sir.
Can you make the comment? Yes.
Yes, sir. Relatively asymptomatic. I was trying to say is that.
No, relatively asymptomatic part is over. You were not
I think Shivani, now that story is over. We are coming back to your, I will say, description. What you said, that is 7 days. In the morning, she was not able to get up. then difficulty in moving the lower limbs. Then even after a few days, you said that it was noticed that the upper limbs are also involved, and that I will say after 7 days, the child is brought to you with this description of the story. Now, having this information, what do you mean by it? That what type of the problem it is, or try to understand that what system is involved and what type of the likely pathology. Can you make some comment? I think there is some net issue, Lata. Frequently, she's,
Yes, sir.
yeah.
So they were that time they were correcting, and I don't know.
And even other students are also probably they are not able to join. They are probably trying, but in between they get the.
Yeah.
Sorry, sir. Sorry, sir, for interrupting.
No,
Network issue.
We understand it is beyond your control. It is control of anybody. So there is no issue. But anyway.
They cannot leave ward, that is the problem, sir.
Yeah. Yes.
Shivani is not able to.
Can you make the comment? I think you have heard from the first slide that what's he described regarding the illness. You have any idea?
Sir wants to ask what is the interpretation on the presenting complaints? Whatever complaints she told, what is the interpretation?
Before that, Lata, I hope that he has listened the story. Jay, are you aware?
Yes, sir.
So what do you mean by it? How do you interpret it?
It might be, sir. There is a, sir, weakness of lower limbs, so it might be related to the central nervous system, more likely.
Okay. Anything further?
Then after, sir, as also the presentation is also associated with weakness of lower limb. So more likely, sir, firstly is central nervous system is.
I think as a whole, if you try to understand the nervous system,
yes, sir,
broadly in two groups. One is the central problem, and another group of the disorders is the peripheral nervous system. Am I right?
Yes, sir.
So in
yes,
this
sir.
in this type of problem, what you are thinking, is it there is central nervous system problem or peripheral?
Sir, as there are, sir, no involvement of any sensory involvement, so
that part we don't know.
Yes, sir. History is still awaited, sir.
Yeah.
Shivani is working on that, sir.
Yeah. So whatever the information, my simple question, from this interpretation, can you make the comment that it looks like the central nervous system problem or peripheral nervous system problem? In other way, if I ask you, suppose central nervous system is involved, what manifestations you are expecting? Personally, I think you should make a video on and come on for the discussion, rather than putting on the chat box. That will be the good way of interactions. Yeah. With the name of Akshat, I think Harshini is there. Am I right?
Yes, sir.
Yeah. So Harshini, why did you say peripheral? Why not
Really
central?
very sorry.
Did you get my
Shivani
question?
is there.
Can you
Shivani is there in the place of Akshat.
I think you put on the chat box that it looks like peripheral nervous system problem. Why do you call it the peripheral nervous system problem? Why not central? I will say it's a central. Because everything is controlled by the brain. Very simple.
Because on the basis of UMN and LMN, I would say,
all these points we don't. All the points we don't know
there is
unless you are. Arshini, let us try to understand.
Spasticity.
let us try to understand. Our aim is to understand rather than to go jump for the diagnosis. My very simple question: what can be the manifestations of central nervous system involvement? Condition may be anything. Yes, some other persons, Ram Ashish Yadav, CNS proximal muscle. Is it so? Anyway, what was my point? Let me make the point clear. In central system problem, what we are expecting that either there may be some ultrasensorium, there may be some seizures, there may be problem of some awareness, some
Higher
even
function involvement.
higher functions in the form of the memory, in the form of even some other activity. These are the things, very simple. And here, on the contrary, she had not made, I will say, any point which indicates the involvement of central nervous system. Even before that, I may ask, why the nervous system? That also we can discuss, but let us wait for some time. So now again, if you say peripheral nervous system involvement, in the neurology, they say, I will say as well in the medicine, more so in the neurology, use the multiple adjectives. Suppose try to understand, is it acute disease, it is subacute or chronic? What will be your comment? What do you call it in our patient? Whatever the condition, is it acute, subacute or chronic?
It is more likely the acute condition only, as 7 days.
Why? Yeah. So we should understand that usually we have some roughly time demarcation to say acute, subacute and chronic. Acute condition usually few days, a week or 10 days. Subacute usually in few weeks. And even chronic condition commonly takes even few weeks to months together. This is just, I will say, very simple point to understand. If it is of only 7 days, say that it is an acute condition. Second thing you can say, that looks like the peripheral nervous system problem. Right. Then second thing you can say, initially that was difficulty in getting up, then lower limb weakness, upper limb, that means it is progressing. What type of progress? It is starting from lower limbs to upper limbs. That means it is ascending. Very simple points, but it provides lot many informations. And in any case, try to put this, I will say, your interpretation. So simply you can say, here is the 3.5 years old female child has presented with the acute illness. Illness looks like the involvement of nervous system, which sparing the manifestations of central nervous system and mainly the locally peripheral. It is likely the peripheral nervous system problem. It is particularly in the form of the motor weakness, which is progressive and which is progressing in the form of from lower limbs to upper limbs, so ascending. That is, I will say. Second thing you can say, whether it is symmetrical or asymmetrical. That also we can understand. Shivani, can you make the comment? Is it symmetrical or asymmetrical?
Sir, it is a symmetrical.
Yeah, why symmetrical?
Sir, both lower limbs simultaneously affected.
Exactly. Very good. Very good. So this is the thing which I want to make out. I want you to make out that this is the symmetrical, because both lower limbs are involved and gradually both upper limbs are also involved. So it's an acute condition. It's a nervous system problem, likely the peripheral nervous system. It is a symmetrical. It is a ascending. It is progressive.
Yes, sir.
And I'm sure that any person can make these are the comments from the first line. And it makes the sense of this interpretation. It provides, I would say, it conveys lot many informations to the part. Right. So I think before we go, I hope that Harshuti Ben is also there and Dr. Anita Madam is also there. Dr. Harshuti Ben, are you there?
Yes, yes, sir, I'm here.
So
I
I
was
think,
just,
Madam, before we go further, you can make your comment, please.
yeah. Sir, basically we had gotten classification which was showing acute onset, subacute onset, and chronic onset. Acute is 7 days, 7 to 14 days, and 14 days beyond. Subacute is 7 to 14 days, and 14 days beyond is in chronic. That is one.
Right.
Secondly, everyone jumps on the telling that this is a CNS involvement and this could be a peripheral because there is no involvement of the higher function. But I would say, why not it is following the trauma? Because
Yeah,
most of the patients,
Yes.
when they come to the clinic, they always complain the child had fallen and he stopped walking. So they went to an orthopedic surgeon. They gave some treatment. The child did not improve, and they usually come to us on third or fifth day of illness.
absolutely.
So rather than jumping, we just, because here also she mentioned that on the second day she was not able to stand properly and the child fell down. So why not it is following a trauma? Why we are jumping on this? So that's a very important point which we
Very
have to
important.
make out.
Yes, yes.
So that is very important, and one has to. Secondly, when you jump to the peripheral nervous system, there could be a simultaneous involvement of the central nervous system as well, even in this patient also.
Yeah.
So I think we should not get biased with the history or the diagnosis.
And that is the
So,
major problem what the madam pointed out. In the
Yes,
exams, most of the times you know the diagnosis.
yes,
So
that's
And
one
very
thing more
therefore,
important.
I would like to add here.
absolutely you are biased, and then your answers are biased. What even madam said, I was going to that point, but I thought that let me wait for some time till they understand. So many things. You may not be the periodic paralysis, may not be following the fall, maybe even something else. Why I will
One thing more, I think you should
directly
also
I will
try to,
jump for this
because
the system also.
this
Yes,
is a
madam, please.
3-year-old child. We
Yes.
can also make out whether it is the weakness which is proximal or distal, because
Yeah,
it could also be a muscle disease. If it was a small baby, then it might be difficult, but a 3-year-old baby, the baby will be able to hold toy or is able to put his finger, eat something. So that is going to help us to differentiate whether it is a proximal weakness or it is a distal weakness. It could be
right.
a muscle disease also. Why we are
Yes,
thinking parents might not be aware of it earlier. So when something happens, then they think it is like that. So I think we should also try to make out whether it is a proximal weakness or it's a distal weakness. That's another point which we should be looking into. And maybe maybe you might be telling it when it is a negative history, but this is one point. And also, was the child crying too much? Because the child will not be able to tell you any sensory symptoms. The child may be only crying. So was the child comfortable or the child was crying? So that will also give us some clue. So
yes,
I think
yes.
these are the points which might help us,
Absolutely.
because it could be a
Absolutely.
muscle disease also.
Anyway, now Shivani, let us go. I will say one more point. Let me make the point. All the students, Shivani, the presenter should not be the nervous, because the things are going even in the same thing in the exam. And this is our, I will say, learning session.
Yes.
Even we can all of us can make the mistakes, even
Oh,
including the faculties. And
yes.
this is not because Shivani is presenting, addressing to you, but this is for all the students. This is for all the students. But naturally, at present, Shivani is seen on the screen and she is presenting. Probably will be addressing you, but this is for all of us, not even for the students only. All the points we'll have to keep in mind in the practice also. So take it, I will say, in that spirit, and don't even be nervous. Problems, mistakes, everything is going to be there. And it should be there. And I think for that purpose, we are discussing, we are presenting. So that is our purpose, right? So now, Shivan, you can take the story further with your next slide.
Unmute Shivani.
Shivani, unmute yourself. You are muted. Yeah, very good. Fine.
Uh,
Go to next slide.
Yeah, next slide.
uh, So with a negative history, so no history of fever, no history of abnormal movements and altered sensorium, no history of vomiting and blurring of the vision, no history of breathing difficulty, no history of difficulty in raising hand above head, no history of difficulty in holding neck, no history of diplopia, drooping of eyelids, no history of facial weakness, loss of sensations over the face, and no history of difficulty in swallowing and protruding tongues, no history of palpitation and sweating, no history of numbness, tingling, and no history of bowel and bladder incontinence, no history of muscle.
Oh, anyway, you complete all the negative points, please.
So no history of muscle pain and joint pain, no history of rashes and skin lesions, no history of diurnal variation, recent vaccination, travel history, animal or insect bite, similar episodes in a family or community, abdominal pain, unknown substance exposure and consumption, and similar episode in the past, and no history of fall down, head injury, trauma to the back.
Okay, is it
Shivani,
okay?
don't mention this blurring of vision, diplopia. How the child will tell you?
Madam, wait for some time. We are coming to the point, please.
Okay.
Yeah. Now, Shivani, you have any negative point history, or these
No.
are the two things? Okay. Now I think we can stop sharing. And
Yes, sir.
I think Madam Dr. Anita was speaking. Madam, am I right?
Yes, sir.
So I think let us take both of you, yourself and Dr. Harshuti later on, the negative points one by one. I think we can take it. Important. I hope that Shivani, or because I have taken the photograph, so I will help you that whatever the negative points she has mentioned and what is the importance.
Yes, sir.
So, Madam, she has mentioned initially no history of fever, abnormal movement and altered sensorium. So please, you can take this point. Importance is relevant to our story, our patient.
So firstly, it is a nervous system case. I want to rule out the rule out UMN lesion from LMN lesion. So I asked for altered sensorium abnormal movements.
Okay. What is the importance of fever?
So fever, associated fever, encephalitis, or any acute acute demyelinating syndrome. To rule
Anyway,
out the
I think what I want to convey, please never go through the condition or so. It's very difficult for even the person. Generally, what we can make out, suppose no history of fever, usually presence of fever indicates some inflammatory condition.
Yes.
And that inflammation may be the infection, that may be the non-infective inflammatory condition, any condition. But I think here, if the fever is not there, probably for me, consideration of inflammation will go down. It does not exclude even. Sometimes without fever, also some infections, some slow infections, or even some inflammatory conditions can present. We cannot totally exclude it. But just we will try to understand there is the absence of the total fever. Probably inflammatory condition may not be in my immediate consideration. Always try to understand the medicine. Don't jump for the upper motor, lower motor, here and there. And suppose if we make out from we will not go for the discussion. We want to understand the importance of every point, and therefore, Madam Dr. Anita was mentioning some of the points very important. And I think again, we'll come to the point. Second thing, as you mentioned, okay, regarding altered sensory, we wanted to say that whether the CRS part is involved or not. Okay. Blurring of vision and vomiting.
So for
Jay, what is the importance of no history of, I would say, vomiting and blurring of vision?
Any history of trauma or raised ICP signs?
Vomiting, okay, but blurring of vision? And suppose blurring of vision is there, what does it indicate? Taking this way, that absence or present, how we are interpreting. Blurring of vision, that means indicates which part of the body is affected and due to what?
So due
Shivani?
to raised intracranial pressure,
Okay.
papillary edema can develop, and pressure on optic nerve can lead to blurring of vision.
Okay. Very simply, I think blurring of vision, it indicates that the involvement of eye.
Yes.
And that can be with several triggers. If it is related to the CNS problem, very simply maybe the ophthalmoplegia, maybe even the involvement of the optic nerve, maybe due to raised integral, so many things that we cannot, I will say, make this very simple comment. Similarly, the difficulty in breathing. Okay.
For progression of the ascending paralysis, I want to ask breathing difficulty.
Again, Shivani, we will not go with a biased mind. Right. If
Yes.
difficulty in breathing is not there, that means very simply I can interpret that the respiratory system or muscles of respiratory system are not involved. Condition may be there. Even in pneumonia. Pneumonia also may be the difficulty in breathing. Not necessarily always CNS problem.
Yes.
Even with pleural effusion. Pleural effusion can also present the difficulty in breathing. Maybe with the tachypnea. Not necessarily always CNS problem. Because here we are biased with the CNS problem. So that's the thing that what we should take care. Right?
Yes, sir.
So difficulty in breathing as a whole, involvement of respiratory system or even the respiratory muscles, which can be nervous system, at least absence indicate that probably they are not involved. This is very simple question, but I think very important. Right? Similarly, difficulty in raising the hand above the head.
So, for upper limb, weakness is there, but not difficulty in raising hand above the head.
That means child was able to move the upper limbs above the head.
Yes, sir.
Then I hope that you suppose if it is there, what will be the power? Very simple question.
Against the gravity, sir. So, power is 4/5.
Anyway, that we can confirm later on examination. But another thing I will say, the exam, don't invite the troubles, right? By making these comments. Holding neck, okay. Diplopia, drooping of eyelids.
Sir, facial nerve, cranial nerve involvement, sir. To rule out the cranial nerve involvement.
Which cranial nerve? We'll have to be very specific.
So third, fourth, and sixth, and maybe due to drooping of eyelid or squint.
Okay. Facial weakness, okay. Understood. Swallowing in palpitation, sweating. What is the importance?
Sir, any autonomic disturbances?
Jay, you can also answer. It's not necessarily only Shivani.
Maybe, sir, it because of
please
autonomic
participate.
involvement,
Yeah.
autonomic nervous system involvement.
Anyway, I think what is a very long list already we have made it. Let us go to the expert that how they should make the negative history, because muscle pain, joint pain, so many points are there. I think every point I may not go into the detail. Let us, I will say, take the help of the experts. Madam Anita, I think you started. Can you just guide that how they should mention the negative history in such patients?
Yeah, she has already told about the respiratory difficulty, that
Yeah.
the patient didn't have any respiratory, because we have to rule out the involvement. It is a ascending type of weakness from your history, acute, ascending. So we have to find out is there any involvement of the cranial nerves? So that is one point. So, well, any difficulty in swallowing, any respiratory difficulty that you have already mentioned. So that is one point which we should be, discussing. Any deviation of the eye, because it is a ascending weakness. If it was descending, your history would have been a different. Then we have also to see where this patient had the weakness of lower limbs, and then it ascended. We have also to find out about the any history of bladder involvement, whether there was retention of urine or child had any difficulty in passing urine, because one by one we have to rule out the causes. So that is another important thing. And the weakness is already symmetrical. So I think the bladder involvement has to be very important, respiratory difficulty and swallowing difficulty. So that is how.
Okay, right. Dr. Harshuti, can you take it?
Yes, basically, what we have to do is when there is a history of weakness, we will find out what are the other areas which can get involved. So Anita Madam has rightly mentioned that we start with a bladder bowel, and then the constipation, then there is a respiratory difficulty, and there is a swallowing difficulty, and ultimately the breathing difficulty. That's the way the weakness goes up. So that is to show the progression. The second thing is to identify the etiology. For identifying the etiology, you should have a history of fever because it is a post-infectious illness. Any of the weakness is usually associated with some illness prior to the onset of a principal weakness. So one has to have a history in a sequence. Sequence is associated weakness followed by the history associated with an etiology. Whatever the cranial nerves and all have been mentioned is all right. Apart from the CNS, one has to have a history of etiology. That is a fever, diarrhea, vomiting, exposure to the toxins, and accordingly. So I think she should mention it in an order. She has mentioned everything all together. Third thing, when you mention the negative history, you yourself should not counteract the presenting illness. On one side, you mention that. Am I okay? On one side, you are mentioning the child is not able to hold.
Themselves, please. Sorry, Harshuti.
Sorry. So on one side, you are mentioning the child is not able to hold in the hand. That is mentioned in the chief complaint. And on the other side, you are mentioning that child is able to raise the hand above the shoulder. So the thing is, whatever you have mentioned, but you should not counteract your complaint. So that is more important rather than mentioning everything in detail. So detailed clinical examination and then detailed history according to the illness, which will help you to arrive at the diagnosis.
Right. I think very simply, Shivani, I said to this one, right? In the exam, suppose something, if you don't have the explanation or you don't have the exact information, better to avoid unless some examiner is asking you. I think here you have mentioned some history of recent vaccination. In what way it is important? Can you explain? Or which vaccine you are predicting, which may create this type of problem?
Unmute.
Shivani, you are muted. Unmute yourself.
So, after vaccination, it can develop traumatic neuritis or
Right.
Other vaccination like polio vaccine and can cause like this type of weakness.
Suppose direct question, if I ask you that if you are suspecting Guillain-Barré syndrome, then which vaccines have the link with this problem? On the contrary, I thought that you might be aware of it.
The influenza vaccine.
Okay. Any other vaccine? Number one. And number two, suppose other, rabies is not responsible for that, but rabies can present in this way. So that is the point what you are taking. Somebody is asking the question in this way, that what is the importance of this point of the vaccination? You can say that suppose some vaccines are given, I presume that the child is protected. Suppose polio vaccine is given. That polio vaccine, injectable, inactivated polio is given. Then I consider that probably this patient is protected from the polio and therefore may not be in my differential diagnosis consideration. But at the same time, suppose not protected from the polio and OPV is given, then probably vaccine-associated polio is one of the possibilities. Similarly, suppose history of dog bite or something, even rabies can present in this way.
Yes, sir.
Similarly, what you said, even the hepatitis B vaccine and influenza vaccine, they are having a link with the Guillain-Barré syndrome.
Yes.
So, in the different situations, if somebody is asking, we should have the good explanation, which is palatable, acceptable to the people. Which animal or insect, because you have mentioned animal bite or insect bite?
Snake bite can also present with that.
Yeah, very
snake
good.
bite or cobra bite. Yes.
Yeah, very good. You can say with this, it is known with the snake. Snake bite can present with the nervous system involvement. It is known and it is acute. It is sudden.
Yes.
And I think it is relevant. Of course, the scenario will be different than the child from some farmer family staying in the farm. Suddenly they noted. That will be the different story. But yes, this is the importance from this point of view. Similar episode in the past. What you want to convey from this point? That means which condition can present multiple times. Suppose patient may recover from this weakness. And then again patient comes back to you.
Hypokalemic periodic paralysis.
Yeah, give some example. But suppose direct question if I ask you, whether the GBS is known to develop repeatedly?
So in chronic inflammatory demyelinating, not repeatedly, but
because you know some candidate is, I will say, having the good performance, my question is going to be changed. Right? And in that case, I will say it is GBS. It was diagnosed last time. Again, he has come with this. Is it possible? Or something was, it was wrongly diagnosed GBS or something? What is your explanation? Ajay, what is your explanation? Sorry, Jay. Is it known that GBS can present repeatedly? Once developed, treated, recovered, again come back with the same picture, same diagnosis?
Yes, yes.
Yes, sir. It may be.
I will say here what best you can do. We have the two experts. Better to learn from them.
yes, sir.
Right. And these are the points which you can ask the questions. Anyway, ultimately we'll go to the madam. Even she had mentioned history of pica. Akshat, what is the importance of pica in this patient? I think just mechanically she had mentioned.
No, sir. There is an importance.
Oh, madam, you have to wait because the student should answer.
Akshat, unmute yourself.
That's why I'm asking the students in this way. Probably, always contradict your colleague that this is wrong way. There is no importance of pica in such patients. Akshat,
maybe nutritional deficiency.
That is a good competition with the, I will say, your colleagues. The first response of, I will say, first response should be there. It is totally wrong.
Nutritional deficiency may lead to
which nutritional deficiency?
Iron deficiency, vitamin B12 deficiency, and that may lead to.
Akshat, another thing in the science, I will just suggest you. You should be damn sure. If you are not, better to remain away. Right? Guessing and bluffing will invite the trouble. I will say, suppose you are second year or third year in the pediatrics?
Third year.
Third year. So you must have seen plenty of patients of iron deficiency anemia, I'm sure.
Yes.
How many patients you saw with this type of picture? That iron deficiency presenting with this classic paralysis, ascending, acute history. Any patient have you seen?
Infantile tremor syndrome associated.
Akshat, answer should be the very precise. My question is very precise. Did you come across presenting with this type of acute classic paralysis? No. never even, I will say, based in the exam also, rather than going on the same, I will say, way of multiple mistakes, better to come back. Even as this tremor syndrome, his presentation is quite different, not this type of presentation.
Yes.
Coming back to Shivani, to you, because Paika you have mentioned.
So lead toxicity.
Yeah, and Madam was actually giving the hint to you.
Yes, it causes painful neuropathy.
Madam
The only
actually was
neuropathy
giving
which is painful is a lead toxicity.
absolutely. Actually, Madam was trying to help you. You know, there are 3-4 examiners. One examiner asking the question, another examiner is giving the hint, and third examiner even answering the question. So that ultimately performance of the student can be maintained.
And
Right.
sir, we have a Dr. Kalpana Datta madam also.
Yes, I know Dr. Kalpana. Yeah,
She can help lots of the students.
so you know what is my question, that this spica, yes, if and even we have seen the patient, not so common, but this staying in some industrial area, children are playing, and with the lead, even the chronic presence with some CNS problems, and even the severe anemia, and that is not responding to iron. So these are the presentation. Yes, no. I think what was my idea to give to the students, that whenever you mention such points, you should have the palatable, explainable, so that it will not create any issue with you. Just to mention is not sufficient. Anyway, so I think another thing, you know, I will give the idea for the negative history, what point should be selected. Not all the whole long list given in the standard textbooks. You should select the point relevant to your condition, which probably you are predicting, suspecting. And the presence or absence of one particular point either strengthens your possibility or excludes the nearby. Such points should be selected, not all. And third group, expected problem or complication of the disease. Here, respiratory muscles, because it is expected. Sweating and tachycardia, it is expected that autonomous system involvement. So expected problems or complications. You want to assess whether the patient has reached to the complication or not. Once you say that there is no sweating, no hypertension, no even this involvement of cranial nerve, so many things you are excluding the complications, which commonly may be there in this type of the presentation, in this condition. So negative points should be very precisely, not very long list, selected, and which very, I will say, somebody is asking you the very good explanation for selecting that point, right? But I will say, Shivani, you have taken the good points, but certainly we should appreciate you, right? Now, now you can take
Sir,
it. Yes, yes.
Yes, sir. Good evening, sir. Actually, I joined late. I started listening from the negative points.
I will
So
say,
if
I
you
will
could
say,
say the presenting complaint, it would be
one point, madam. Not looking at you, I will say her picture in the screen. Just from the voice, I say, Doctor, she is Kalpana Dutt. Am I right, madam?
Yeah.
Perfect, sir, perfect.
So please, you can take it further, madam.
Oh, actually, I wanted to know what was the presenting complaint. I joined from the negative
Yeah, madam, just I
points.
will inform you. Here she had presented 3 years and 5 months female, total 7 days of the history, and she mentioned that one day morning she was not able to get up, and then the weakness of lower limbs, gradually it progressed to the upper limbs.
Okay, I got it.
I think these were the main problems of
Yeah.
the
So I
presentation.
would like to, I got it. So it is an ascending type of paralysis she meant to say. So it's very important, as she has already said, onset of the paralysis. It is a sudden or a rapid onset or very rapid onset, like in a traumatic and all. Onset within 2 to 3 weeks, onset within weeks to months. So onset is very important. As she has said, in the morning she mother noticed but baby could not. That is the sudden onset. Then progression of the disease is also very important. Progression, maximum deficit, like in traumatic, there will be at the very beginning, at the onset will be whatever that paralysis will be there is own progress. So progression of the disease again very important, hours to few days or weeks. Then type,
Absolutely.
Yes, the cell type ascending. As she has said, it is typically ascending. So they should know what are the causes which can cause ascending paralysis, like GB, as you have mentioned, rabies. Varicella zoster can also cause, and tick bite paralysis. These are the
Yes.
things which can cause ascending. And simultaneously, examiner may ask what is the descending type. Then they should know diphtheria, botulism also can cause the descending type. So it's very important for that for the postgraduates to know. Then what is the topography of the paralysis, whether it is symmetrical or asymmetrical, whether there is any cranial nerves involvement, because many diseases which are very much prone to develop cranial nerve involvement. So these points are very important. Then, as Madam said, also bladder bowel involvement, sensory symptoms. Fever was there at the beginning or at the history of the fever, because viral myositis can present with the weakness because of the pain. So fever will be there at the moment. But in the case of GB and all, there may be a history of fever. Similarly, autonomic signs, preceding infection, any like history of if it is thinking descending type, then the constipation, honey intake, previous history of diarrhea, trauma, animal bite, as you have already mentioned, sir. And then, of course, rare cases, acute intermittent porphyria can have like this. So, abdominal pain, rash, neuropsychiatric manifestations, all those things to be, I think, asked in the history. This
Absolutely.
much from my side.
Yes.
Thank you, sir, for giving me the opportunity.
Anyway, Shivani, you can take it further. Because we have not even completed the history. But one thing, let me even emphasize over here. It is said in neurology, 80% diagnosis should be revealed from only history.
Oh, I thought it's finished. Okay, it's okay. Thank you, sir.
Shivani, now we can complete the history, then we'll be back.
Sir, with the past history of fever and loose stools, 12 days back for 2 days, which was low grade fever and relieved with medication within 2 days.
Is there any importance of this history, Shivani?
Sir, yes, sir. In case of GBS, there is a significant history of diarrhea before 10 to 12 days.
Can you point out which particular organism is considered
Yes, sir.
culprit for that?
Campylobacter jejuni is the culprit for this type of presentation.
Can even upper respiratory infection can also create this problem?
So yes, EBV virus and cytomegalovirus can also cause.
Anyway, okay.
And now it is, as it is said, 30% of cases are proven fact that Campylobacter jejuni, and Helicobacter pylori is also proven fact. Now it is proven.
I think this is for the students to keep in mind for exam point of view, because such questions are going to be there. Fine, please take it further.
With no significant family history, birth history was uneventful, and normal vaginal delivery with no NICU admission.
Okay.
Immunized till 9 months of age, and no then 1.5 year vaccination is pending, and all developmental milestone achieved on time.
But I think here immunization history again, please, whatever may be the case, some examiners will be interested to discuss the immunization. So I think till 9 months, that means it is as per the National Immunization Program. Am I right?
Yes, sir.
Shivani?
Yes, sir.
And then further, I think, as Madam was already mentioning, it is not sufficient. Probably influenza vaccine they might have received because not available in national program.
Yes, sir.
So similarly, even the varicella also might not given. So all these vaccines are also important, and you can make the comment that vaccination till the age of 9 years as per the National Immunization Program. Okay.
Yes. So all developmental milestone achieved on time. Dietary history with a 540 kilocalorie deficit and 6 gram protein deficit.
Okay.
I would like to summarize my history as a 3-year, 5 months old female child, partially immunized, developmentally normal, presented with a weakness in all 4 limbs, lower limbs followed by upper limbs since 7 days, acute in onset, rapidly progressive, symmetrical, ascending in nature, without any breathing difficulty or bladder bowel involvement. with a past history of diarrhea.
Good. I think good summary. Most of the points you have included. With, I will say, lack of time, straight away you can go for the examination.
In general examination, child was conscious and oriented. Child appears malnourished and poorly built, with a no pallor, clubbing, cyanosis, lymphadenum with jaundice and edema. In vitals, temperature is 98.2 degree Fahrenheit by a digital thermometer in right axilla. Pulse rate is 88 per minute in a right radial artery with a good volume and normal rhythm. Respiratory rate was 28 per minute, regular thoracic type of respiration. Blood pressure was 116 by 78 millimeter of mercury, and the saturation was 97% in a room air. In anthropometrics, weight is 10 kg, length is 90 centimeter, weight is less than third centile, and height is between third to 10th centile, and mid upper arm circumference is 14. So weight for height is third to 15th centile. In head-to-toe examination, no significant positive finding. I would like to elaborate central nervous system examination, as my patient has a complaint of weakness in limbs. In central nervous system examination, high mental functions, alert and conscious, oriented to time, place, and person. Child is able to recall recent and remote events, and speech and language is good, with good comprehension and good fluency, talking to parents normally.
Shivani, if I ask you the direct question, can you
Yes.
go to the previous slide? At what age you can assess the orientation of time, place, and person? At any age? Or is there any specific age?
So,
in other way, whether the 3.5 years old child, can you assess the orientation of time, place, and person?
so she can appreciate that he is not at home, or
Anyway, to save the time and from exam point of view, orientation of time, place, and person usually after 5 years.
Yes.
On the contrary, how you can assess the functions of the child of very young child, right? That
Yes,
alertness activity is whether the child is alert, paying the attention to the surrounding, looking at the mother, even playing with other children. If you offer the toy with the child is accepting, and then what child is doing with this toy, according to the age even. So, these are the things, how you can assess the higher functions in young children. Not in the form of this level of consciousness, orientation of time, place, person, then even the speech, memory, intelligence. I think that's not, may not be, I will say the same points may not be applicable for
yes,
the
sir.
young children. Yes, these are the same points we are assessing, but with some different method according to the age of the child. So that we'll have to know, right?
Yes, sir.
Please just only keep this point. We can discuss many things in details, but just to bring this point to your notice, that according to the age of the child, we'll have to know that how we can assess the higher functions. Okay.
So all cranial nerves are normal. No.
Okay,
Any,
I think to save the time, we consider that all the cranial nerves normal. And how to examine.
In modern nervous motor system examination, there is no obvious atrophy, hypertrophy. In tone of the muscle, patient is bedridden, and the hypotonia in all full limb. Muscles are flabby on touch, and saccability test is positive. Power of the muscles.
What you want to convey with the pitching frog position? Or in other way, which condition characteristically this position you will see from the distance?
Frog position.
Anyway, I think at the end we'll take the help of the experts, but these points are very, very important. Please, because I'm looking at the time, so we can discuss, we can spare some time for the discussion. you can complete the examination.
Power of the muscles in upper limbs, there is a 3 by 5. Power is 3 by 5.
I think you have mentioned all the places 3 by 5, right?
Yes, sir.
Okay, go ahead.
So in a lower limb, there is no power at all. Reflexes, superficial reflexes, conjunctival and corneal reflexes is present, and abdominal and plantar reflex is absent. Deep tendon reflexes, biceps, triceps, and supinator reflex was grade 1, and knee jerk and ankle jerk reflexes was absent. Sensory system, all sensations are intact, no autonomic system involved, and the bladder bowel is continent. No cerebral function tests are not able to perform properly due to weakness. She was trying to perform, but some weakness was there. So finger nose test and finger test, she was able to perform with less power, but she could.
Shivani is such patient, better to make the comment for cerebral functions that all the tests are not possible to perform.
Yes, sir, not
but
possible.
whatever I could observe, it indicates that probably cerebellum is not involved. Right?
Okay, sir.
Okay.
Yes, sir. Other system, cardiovascular system, heart sound was normal, no murmur. Respiratory system, normal. Bilateral air entry was equal, and upper abdomen soft and no organomegaly. After
Okay. I think summary we can go later on. Dr. Harshuti, can you take examination point, particularly
Yes,
the
yes.
CNS?
Let's
Please,
start
please.
with one, the higher function, and then the position. I think position was more important. Higher functions you have already covered, but when you want to mention something regarding the higher function, what you need to speak is child was active, a child was playful, and he was responding to the commands.
Yeah.
That almost, it covers almost everything. That's the best way. Second thing is with from position, it suggests a power grade 2. And the child, what's the history, what the examination they have mentioned shows that it is a power was not there, hip, knee,
Grade
and
0.
ankle.
Yeah.
So I never learned what is pith frog position. I had to Google and see, because what we have learned, what we have seen in practice, it is always flabby muscles when the power is 0, you know. So the position has to be mentioned accordingly. The flabbiness of the muscle, which you cannot make much, but the position of the joint matters a lot, right? So that is the first thing which you have to see. And what about the reflexes? See, when you mention about the muscle, it comes to the tone, power, and reflexes. So that these are the most cardinal points which we have to mention. Regarding the respiration, you have to mention the type of a respiration rather than the respiratory rate or a breathing, because that comes out more of an abdominal type or a thoracic type. Like that is more important with in respect to the history which the patient has. So when you mention a particular system examination, you always mention it, the type or the organ which is involved. So that is more catchy, you know. So I would suggest that you should mention all those points.
Dr. Shivani, can you make the, I think before we go further, Madam Anita, anything from your side?
Whatever you can't do, you should not mention. You mentioned about the sensory system. It's so difficult. You can only say that grossly you could test the pain, touch. So you should not be writing all the points which are given in the book, because you cannot do those things, as sir has already said. You are writing autonomic nerve functions. Then you mentioned about the first cranial nerve. You cannot test in a small baby. First cranial nerve. So whatever you have not done, you should not say in the examination. Otherwise, you will be caught there. Then there is a weakness of the truncal muscles also in this patient. because the child couldn't sit. So you should have mentioned that also, that the child has got the weakness of the truncal muscles also. So that has to be mentioned. Neck muscles, of course, you were mentioning, but truncal you didn't mention. Then the in all CNS cases, I think you might have mentioned the head circumference, but I might have missed it also. You should also mention about the meningeal signs also. Never presume that they are present or they are absent. Similarly, when you have a patient of weakness of the limbs, or whether it is ascending or descending, in the spine, you have mentioned scoliosis and all that, but always mention that there is no sinus or anything which is any deformity, tuft or affair, because we have seen in practice patients coming as GBS, but they had the spinal abnormality. So your examination should mention all those things. You should not think that I am only dealing with a patient of GBS. So I think these are the, and then when you are mentioning the CNS examination or any examination, like in the muscle system, it has always to be inspection, palpation, and that is the sequence. So you mentioned the position of the limbs later on, and the power a little earlier. So it should be a sequence because it is an examination, not that you are writing like a consultant or later on. I think these are the points which I like to mention.
Absolutely. So I think exam point of view, both the experts pointed out several points.
Sir,
Every
can I say
yeah.
something?
Yes, madam,
Sir,
please.
actually, sir, heading she has written examination of central nervous system. Ideally, it should be examination of nervous system, not the central nervous system.
Yeah.
So
Traditionally
then
we say CNS, but I think nervous
it's the nervous
should.
system. Then and the heading will be high functions, cranial nerves, motor system, sensory system, and other systems will be there. Okay.
Yes,
The rest of the thing other two experts already said.
Fine.
Thank you.
I think, Shivani, in such cases, you before you go for this diagnosis, always keep the habit of summary. And that too, I will say positive findings on CNS examination. Let us focus on the CNS, nervous system examination. How will you put the summary of the positive findings? And then draw the conclusion that what are your possibilities? Right. I would say make the attempt. Naturally, I understand. You might have not thought of, and just even blankly, and I'm asking the question, so you may not be prepared. But still, I think you can make the effort. That how best you can do.
With the positive findings of hypotonia in all limbs, no power in lower limbs, with the decreased power in upper limbs, areflexia, and intact sensation without higher mental function, cranial nerve, and bladder bowel involvement without autonomic autonomic disturbances.
Okay. I think very simply we can put over here in this way. That on examination of nervous system, apparently I noted that the higher functions are normal, cranial nerves normal. On motor system examination, I found that this is a generalized hypotonia, and even power different in upper limbs and lower limbs. Lower limbs grade 0, upper limbs I think 2 or 3, whatever you have mentioned. It's a generalized hyporeflexia, and even the plantar absent.
Yes.
With the cerebral signs of mental irritation absent. Having this type of presentation, I understand that it's a problem with the peripheral nervous system. And here also you can, I will say again, for the sake of exam, or I will say learning point of view, peripheral nervous system, try to define. Is it the anterior horn problem? It's a peripheral nervous system? It's a neuromuscular junction? Or it's a muscle problem? And every group is having the very characteristic, starting from the history to the examination. And then you can make out. And so simply, if I ask you the question, can you make the comment that what type of this flaccid paralysis problem in this patient? Starting from the anterior horn cell to peripheral nerve to neuromuscular to muscle, what is your comment?
Due to areflexia and intact sensation, I would like it is peripheral now. At the problem is at the level of peripheral now.
Can you give some characteristic of the anterior cell pathology disease? One characteristic. All other features will be of acute placid paralysis. But some features which you can say that, yes, this is highly suggesting anterior horn cell disease. These types of questions are going to be there in the exam. And even you can remember one prototype condition. Can you name the condition?
Transverse
anterior horn cell disease? Yes.
Transverse myelitis, acute transverse myelitis.
Is it anterior horn cell disease? Very simple. Verdig-Hoffman, any muscular dystrophy, variety, there are so many varieties. Poliomyelitis, these are the anterior horn cell conditions.
Yes.
Right. Similarly, neuromuscular junction.
Snake bite, myasthenia gravis.
Best prototype, classical example, myasthenia gravis.
Myasthenia gravis.
Right. There are some other conditions presenting, but commonly prototype, very classical picture we can remember. And what is the characteristic of the neuromuscular junction presentation condition? Usually fatigability.
Easy fatigue.
Progressive fatigability. Ophthalmoplegia. Right.
Yes.
Very simply from the history probably you can make out that this is a problem of neuromuscular. Muscle pathology also.
Viral myositis.
In viral myositis, what is the problem? Weakness is not, I will say, due to the neurological problem. Mainly, it is not moving the limb due to the mainly pain. One person is not moving the limb or difficulty in moving the limb. Try to understand that is it really due to the pain or really due to the neurological condition. Most of the times in viral myositis, due to the pain, child is not moving the limb, rather than really neurological involvement. Of course, that can also occur. Right. So this is the thing that how we can try to differentiate. Okay. Now, can you say that is it ultimately what is your possibility?
So a possibility is first of all GBS, Guillain-Barré syndrome.
Okay.
The snake bite.
What are the points favoring the Guillain-Barré syndrome? Whatever the point condition you say, you have to find out what are the strong points which strengthens your possibility.
So acute in onset, rapidly progressive, ascending with hyporeflexia and areflexia with hypotonia, without the bladder bowel involvement, with intact sensory sensations. The strong positive findings.
Suppose similar picture, but bladder bowel involvement is the very strong point. Does it make difference in your thought?
So then it can be transverse myelitis.
Very good. Okay. Similarly, there are any, if I ask you the direct question, should I consider poliomyelitis in this patient? Whether it remains one of the possibilities or you exclude this poliomyelitis?
Exclude the poliomyelitis.
Why?
In a poliomyelitis, proximal muscle.
It is said, Shivani, that most of the conditions characteristic what we discussed, yes, but not all the patients will follow our classical picture because they have not read the Nelson.
Yes, sir.
Most of the GBS will be symmetrical, but occasionally asymmetrical involvement is also known. In polio, asymmetrical patchy involvement, but I think very past, if you remember, yes, we have seen not so common, but even the symmetrical in poliomyelitis. Common presentations you can take. So you cannot exclude totally polio. You can say, yes, having this picture, poliomyelitis goes down. Even second thing you can say that already we have reached for the poliomyelitis, this level of the elimination, then it goes again the less possible. But suppose if you had on polio, which variety of polio can occur in this way? Which variety? In this era, where already we have got, I will say, this much achievement for elimination of the polio.
Vaccine derived paralytic poliovirus.
Okay. Whether the vaccine derived polio is more possible or circulating this virulent pattern of the virus. Anyway, I think that you'll have to read more. Already we have reached to the time of, but one thing is very certain. Have you done any exercise with this acute facet paralysis of this patient? Have you reported what I mean to say?
Surveillance.
Yeah, have you done?
Yes, sir.
What
We
you
have
have
done.
done? What you have done?
Sir, we notify the this patient to the PSM department, and WHO person came for the stool sample within 48 hours.
Shivani, you called to whom? You know, being resident, I think I'm sure a teacher must have talked to you that go for the AFP surveillance.
Yes.
Then immediately, to whom did you talk? Your dean, your superintendent, or some other authority? To whom did you talk?
So we talked to the PSM department and
okay. Why the PSM department? I think PSM department people are good. Otherwise, they will tell you that why you are informing us.
We have eradicated polio, so it is a notifiable disease if any case is there.
Yeah, Shivani, why I'm asking this question, very practical, and that gives me the idea that how much as a resident you have passed through the process. The person who has done has not to think. And then second question, anyway, after this information, who came to your place and what he had done?
Stool sample was sent.
How much the stool sample has taken?
2 stool sample. So,
amount of the stool. Is there any guideline?
8 gram of minimum 8 gram of stool sample.
Very good. At least remember 8 to 10 gram. Good. But how you are going to weigh? You are not going to weigh this stool. So how you decided that yes, this is a sufficient amount of stool for the examination?
So there is a container where there is a mark.
I think somebody is putting the good answers on the chat books, but unfortunately they don't come on the screen to answer. Yeah, yes, it is
absolutely
a thumb size.
Thumb size.
It's a thumb size. Very good answer.
Yes,
right. And 2 samples at a time. Suppose he has not to come back, so he will say, "Abhi मैं 2 sample लेके जाता हूँ." चलेगा?
No, sir. At least 24 to 48 hours apart.
Right.
2 samples, 24 to 48 hours apart.
Then what they do?
They look for the polio virus.
How? They will look for? Which center they send? Any idea?
WHO associate WHO connected.
I think WHO center this is located at Geneva. So are you going to send these centers at Geneva?
So laboratory which is also connected with the WHO, accredited laboratory.
What was my idea, Shivani, with all the series of questions? Being, the Indian pediatrician, and we have reached to the level of elimination of this polio, we are supposed to know each and every aspect. every pediatrician.
Yes,
That even any patient of acute flaccid paralysis, up to what age you are going to inform
15
surveillance?
years. 15 years.
But somebody says even beyond that, I have done even at 40 years. Is it right or wrong?
Yes, but name is different.
Name is same. Anyway, after how many days you will get the report? How I can confirm that yes, it was what I thought of the GBS was the poliomyelitis? Yes, Harshini is putting the answers. Very good. In a 60 days follow-up.
Yes.
And if there is a residual effect, that favors this poliomyelitis. Anyway, Harshini, I think, are you there? You can come on the screen. Some of the, I will say, questions I want to ask you. Harshini, would you like to come on the screen? Anyway.
Harshini, unmute yourself and come to screen.
I think students should come forward without any hesitation. We can be wrong even. Nothing is, even some teacher, all of us, anybody of us can be. Anyway, no problem. When the last case of poliomyelitis is reported in India?
In 2014.
Yes.
Last case is reported.
Which date and from which place?
Sir.
You can take the help of Madam Dr. Kalpana Dutt.
In March?
That was 13th January.
13th January.
Right. And that was from Kolkata.
What was the, sir, what was asking? I was just
last case of poliomyelitis reported from India.
Yeah, last case of poliomyelitis is one of the Metia Bruce place in Kolkata. It was from the sewerage.
That's why I said that Madam Kalpana will help you.
Yeah, it was from the sewerage, and there are some people coming from the outside, like Afghanistan and all at that place.
Yes.
So it is found from the sewerage of that area.
Anyway, what was my idea, Shivani, and to all the students? We should be prepared for certain aspects which are going to be the very common, even similarly for polio vaccine also. So many, I will say, controversies, so many compromise, I will say, schedules, and which one is ideal, everything we should know. But I will appreciate you being given the third year resident. You answered very good. I think before we end, any comment from Madam Harshuti Ben or Anita Ben?
Sir, we missed the good teachers in our times. If you would have been there, we could have been a very good pediatric neurologist. So nicely you are asking the case. I'm literally surprised. Anyway, it is always so. There's nothing like new to us. But it was a good attempt. What I personally feel is they need. It was a very good attempt for all of them, by all of them. But I think, sir, can't we keep some teaching to the for the history taking for the particular system every time?
Yeah, I think that's good suggestion. We can convey to our organizers. They can modify, but very, very certainly. Shivani, somebody is going to ask the question that already you have hospitalized the patient of GBS in the ward. How will you see for the developmental complication, particularly respiratory complication?
Sir, if child is abduct the shoulder.
Very simple, not to save the time. Single breath count.
Yes, a single breath.
Yeah, very simple clinical bedside test. And really your nursing staff has maintained, you understand that patient is before the manifestations, sudden manifestations, you can make out that prepare for the ventilatory support. I'm sure that clinical medicine is even in this era, our AI probably may not be able to reach, but the good clinician will be able to reach. And if you have maintained the chart even, we understand that yes, this patient is going for the respiratory muscles problem. And suppose if you don't have the facility, you can actually transfer the patient with the facility, because certainly you can say that this patient is going to need this ventilatory support. These are so many, even the predictors for the bad prognosis, what we are discussing. One of them, very, very fast development. Even obesity. Obesity, I will say, having a very bad prognosis. So, even in our country with the malnutrition. So there are some predictors which you have seen in your patient. We can remain alert that this is not the good patient. Can go for the problem, complication, mortality at any time. I have seen recently, just few months back, 75 kg weight. Not recently, I will say 1 year back in GCS only. 75 years weighing child with a GBS died within 48 hours. And obesity is a very bad, I will say, predictor. And now gradually it is coming very common problem, obesity. So I think as a clinician, we'll have to learn all the things which are very, very important. But one thing, Shivani, I will appreciate you that you have selected the good case. And even initially, I could predict that sometime you were nervous, but later on you could look after yourself and strongly, very nicely you presented. Certainly very nicely. And I understand as a teacher that, after 1 or 2 years or 3 years residency to present the case in this way, on this type of I will say, spectrum, certainly it needs, I will say, the courage. And you did very nicely. Also, some of the points were good. Yes, we can go for even the scope of improvement is always there. We can even go for that. Even our experts, that very simple points, but how they help us. And yes, the whole team, also starting from Yogesh Bhai to Nailban to even the Dr. Lata, they are taking so much pain, finding out the person, good presenter, mentor, and then even this finding out the good experts, and the whole team is prepared. So we know that it requires really good efforts, and they are doing so. And that's why all of us are learning. Somebody is doing so much hard work for our learning that always we should understand. And really, I should always express a word of gratitude to them that they are giving me this opportunity for learning. Thank you very much. Thanks a lot. Over to you, Dr. Lata and Yogesh.
Thank you, sir. It's our pleasure.
Thank you, sir. Thank you for encouraging words, and Dr. Nehal Madam, Dr. Lata Jha, under the guidance of Dr. Jankna Madam, doing excellent.
Yes. Our president is very vibrant, I will say. She's doing, I will say, good job.
Yeah.
For all of us.
And thank you, Shivani, for the.
Thank you, sir. Thank you.
Yeah.
Shivani, next time you can do. Ask your colleagues to join.
આના પછીનો નેક્સ્ટ સેશન છે ને આ જ સિસ્ટમનું એક્ઝામિનેશન ડિટેલમાં લેવાનું રાખીએ. બહુ જ ફાયદો થશે છોકરાઓને. યોગેશભાઈ જેમ કહે તેમ, જંખના જેવું કહે તેવી રીતે. પણ આઈ થિંક વી શુડ, એટલે શું કે એક કન્ટિન્યુએશનમાં દે લર્ન એવરીથિંગ.
Yeah, actually, madam, we have the same format previously in the past years. You also were there for as an expert. Kalpana madam, Anita madam are the regular our faculty for the Gurukul program since last 5 years. So, but now this year we have changed the format little bit. One case presentation, one quiz, one panel discussion, one expert talk. So next CNS system we have after.
I think there is one provision is there under this, I will say, presidency of Dr. Jankna Ben, that they have planned the postgraduate teaching session at different colleges.
Yeah.
I think during that time we can do, I will say, physically and we work on the patient. And meanwhile, I think making the team, we can take the help of the experts also. Each system.
That is also there. Physical sessions will be there.
So I think this suggestion can be incorporated with that sessions. And
so the full one day we can give to the students for
Yes. Thank you very much. Thank you.
Thank you, Harshuti Sharma sir.
Thank you, Dr. Yogesh. It was a good session, Dr. Prajapati, and I think Shivani had so many external examiners today.
Yes.
My best wishes to you. My best wishes.
Yes.
Yeah.
Okay, thank you so much.
Thank you,
Anita ma'am.
and thank you all the
ma'am.
students. Thank you all the students for participating very actively.
Yeah.
Yes.
And
Thank
do
you, sir,
the
for
same. Yeah.
That's awesome.
Yes.
Our senior most
Thank
vice president also learning so much every day. Satish Sharma
Creative
sir.
neurologist, Dr. Yogesh.
Yeah. Medical legal experts. Sir, you can also contribute a little bit in the legal way.
Yeah.
Yeah. So
Thank you,
thank you
everybody,
everyone.
and
Thank
good
you.
night. Good
Good
night.
night.
Good night. Good night, everyone.
Yeah.
Thank
Good
you,
night,
everyone.
everyone. Good night, sir.
Good
Bye
night.
bye.
Next session
Bye-bye.
will be the OSCE
Bye.
session by the
Thank
Baldev
you and
Prajapati
good
sir.
night.
Yeah. Please, I will
Yeah.
say, I request everybody, please come with some
Next.
good preparation and interactions. We'll have the
OSCE.
good cases are there in the OSCE, and I'm sure that the DNB exam and even your MD examination with the spot and even Vivas, you are going to be benefited. So, large number of
Yeah.
students. Thank you very much.
So encourage your friends across the means wherever your friends in the Gujarat or across the country where they should participate actively and learn from our expert team of the Baldev Prajapati sir and all the faculties.
I think it's very good, sir, because it takes out lot of anxiety when you are appearing for your final examination.
Yes,
Because
madam.
you have so many externals, and I think 95% of questions will be covered by this. Only 5% are one which can be, just
Something new.
you read the journal and you ask the question just from the student. Otherwise, 95% of questions will be these only. Unless you answer
So
this, you can't go beyond. So I think
yeah,
this is a very
that,
good platform for the students. Very good platform.
yeah, Anita madam, let me congratulate Baldev Prajapati sir and the team because
Yeah.
since last 5 years we have this Gurukul program and those who are presented 2 or 3 cases in this platform, they are the gold medalist.
Yeah.
Yeah. So,
Yes.
Good
Yeah.
record.
Always it is rewarding, certainly
See,
rewarding.
I can give the name Aditya Bhatt, Anna Roy, and the Chinmay Desai.
But Yogesh bhai, because you have mentioned,
Yeah.
these two students were really so regular.
Yeah.
In every case, they will be there. And not just present, they will be interacting. I remember both of them. And I think, yes, of course, their capability, but with their capability, with this, I will say, discussion, they got even the good score in the exam also. So
Yeah.
it makes difference. It makes difference.
So I request Dr. Lata, who are this zonal coordinators, at least they should present every time. So at least they can guide their students and how can this we have to coordinate the other colleges.
Right.
Yes, sir. Yes,
What are the
sure,
stage
sir.
means how to go with the students' preparation, including the
That's right,
demo.
sir.
Yeah.
Yes, sir.
Yeah. So thank you everyone. Thank you, Jhanna madam,
Thank
for
you and
the
good night. Thank you and
active
good night.
listening and the participating.
Yes.
See, madam also with me, my senior, while I joined as the assistant professor, madam was the associate professor. And she is also currently also in the medical college, again joined the Rajkot Medical College.
Yes. Yes.
Yeah.
Thank you.
Thank you
Thank
everyone.
you. Good night.
Teacher
Good
always
night.
stays teacher, sir.
Yeah.
Yeah.
Teachers remain always teacher. Yes.
Yes.
Yeah. Lifelong learning.
Yes.
Yes.
Our full-time Srinivasan sir, we are missing. Otherwise, sir is always there with us.
Sir,
Yes,
Very
yes,
sir,
nice.
last
Very
sir
nice.
is at US at present.
Yeah, but he can join anytime from the US.
Yeah.
Yes.
Yeah.
Yes.
So also neonatal Pathshala you can join because there also the so much cases and neonatal learning is there. Many experts are there. So student you can join there also at Wednesday 3 p.m. 3:30 p.m. Only 1 hour you can spend and you can cover whole the newborn topic. And next month we have also the newborn series, case series and the
Yeah.
panel discussion.
Yes.
Yeah. Thank you everyone. Thank you.
Okay.
Thank you.
Thank you.
Good
Good
night.
night. Good night.
Good night,
Night.
everyone.
and good
Good
night.
night.
Good night.